Great. Welcome, everyone, and thank you for joining. We might just give this a couple of minutes before we get started. And while we're waiting, please feel free to introduce yourself in the chat. The Q&A box is for any questions and answers during the presentations, but feel free to post an introduction or a LinkedIn profile. We'd love to know who is on the call. And feel free to also, as we go through the talk, plug in with questions or reflections on the findings. Great, so I can get us started. Welcome everyone to this webinar today. I know we've had a long year of webinars, so I certainly appreciate everyone's interest and enthusiasm for this webinar in the midst of the summer break, I guess. So we are here today presenting our third round of findings from the third round of the National Pandemic Pulse Survey. It's a nationally representative survey across the US that is really focused on assessing inequities in how the COVID-19 pandemic has been experienced by the population across the United States. Next slide, please. So as we have noted, in the last year, the epidemic has not affected all Americans in the same way. We see a much higher rate of infection as well as mortality rate amongst minority communities, especially Black, Hispanic, and American Indian or Alaskan Native populations. So this is an unacceptable difference, and it is largely driven by, in many cases, by compounded inequities and injustices that are resulting in socioeconomic disparities and really exacerbating the effects of the pandemic. Next slide, please. So as Boyd and colleagues here elegantly framed it, this disproportionate mortality really exposes deep-rooted institutional racism that is at the heart of what we see with the US epidemic. And it'll continue to have, even beyond the immediate end of or near-term end of the effects, it will continue to have long-term implications on communities who have experienced the compounded effects, harms of the pandemic. Next slide, please. So the National Pandemic Pulse Survey is a repeat survey that is deployed across a representative US population to measure disparities and inequities in the experience and impact of the COVID-19 pandemic. And really the strength of the survey is in the cross-disciplinary research focus, where we have experts with expertise in mental health, food insecurity, substance use, economic impact, access to vaccinations, and so on, who are able to look at essentially how certain communities experience the compounded effect across multiple aspects of living and livelihood on their lives. And so we're really able to look at, for example, a combination of how does food insecurity and mental health affect certain communities more than the other, because that really compounds people's ability to cope with and to have and how they experience the pandemic downstream. As with each round, we've been able to revise questions to capture the most pertinent concerns, and as well as retain a lot of questions so that we have some level of longitudinal comparability between the rounds. Next slide, please. For those who are interested in more details, we have a website at covidinequities.org right here on the top, and with several brief summaries of our research findings, as well as an interactive dashboard that can be used to look at data in other ways. So if you are interested in disaggregating data in a certain way that's of interest to you, you can do that through the interactive dashboard. Next slide, please. We also have a number of manuscripts that you can find on medRxiv or in journals that where they've been published. But also for a briefer summary, you'll see that we have these policy briefs on our website. So with that and without much ado, I will introduce the panel for today. Next slide, please. We are going to talk about disparities in COVID-19 testing and outcomes. Dr. Jeff Edwards is going to talk about that. And then we'll have two presentations focused on experience of pregnant women, specifically on vaccines and on maternal and newborn outcomes. And finally, we'll move to trends in mental health as well as substance abuse. This is part one of a two-part seminar. The next seminar is next Friday, where we'll talk about vaccine acceptance and hesitancy, masking intentions and misinformation, food insecurity, as well as schooling. So you'll see that we are really taking a multidisciplinary lens in looking at inequities in this study. So with that, I present to you Dr. Jeff Edwards with disparities in COVID-19 testing and outcomes.
Or I'm going to jump in.
I will stop and I will I'll hand over to Dustin to go over the methods for the study.
Thanks, Dr. Agarwal. As Smisha just mentioned, so I'll just spend the next few slides briefly going over on methods before then passing it over to Jeffrey and the team. But as Smisha mentioned, our objective is to quickly capture the pulse of the nation through multiple cross-sectional surveys over time. And typically these have been every couple of months. As indicated by Smisha, the survey contains questions from both existing surveys as well as those identified by team members that appeared to be lacking in the literature. The final questionnaire was reviewed by folks here at the School of Public Health and our School of Medicine. The survey contains a core set of COVID-19 questions that we will ask in each round to see how they change over time, such as COVID testing and outcomes, as well as the ability to add in new trending topics, for example, school reopening in September, and behaviors following vaccination in this survey. I would like to highlight that our large sample size, almost a little over 9,000 in this round, makes our work unique from others in that it allows us sufficient statistical power to examine health inequities in subpopulations. So being able to look at different race, ethnic, age, and gender groups and how COVID is impacting them. Next slide. Thank you. We've contracted Dynata, which is one of the largest first-party data platforms in the United States, to deliver our survey. Dynata sent email requests to a targeted but random sample to create a nationally representative survey on gender, race, income, and age and census division. The survey was an online survey program using the enterprise version of SurveyMonkey, and participants were eligible if they were 18 and older and a US resident. The exciting results that we'll be sharing today come from our third survey round conducted late May through early June of this year, where we received approximately 9,238 surveys, complete surveys. Next slide. As mentioned, this is our third round of data collection, with our previous two rounds occurring in September and December of this past year. Our team is furiously at work putting together our questionnaire and survey for an upcoming fourth round to be released soon. Next slide. Our most recent survey, as always, includes a set of sociodemographic questions, and this time 10 COVID-related modules, with the bolded modules such as mental health, trust, and food security, representing topics that have been included in previous survey rounds. Next slide. And I won't spend too much time on this slide other to point out that you can see that our targeted quota sampling approach produced similar estimates. So blue census, red pandemic pulse, and we had similar estimates on female on the left, the race and ethnic groups, as well as age. Just click, please. And the pie chart on the right is just showing the income of our respondents. And you can see that about 20% of our sample are reporting an income of less than 25, 30,000. So this matches similar estimates for the US. Just to wrap up before passing the baton on to Dr. Edwards, I and our team would just like to emphasize that these results are preliminary and or univariate analyses unless otherwise indicated. We thought it was important to get these results out as soon as possible rather than to conduct more elaborate analysis. So unless the slides indicate these are adjusted models, just to bear in mind that these are often just bivariate analyses. So, thank you.
Great, thanks. So I'll be talking today and giving a broad overview of the COVID-19 testing as well as COVID-19 outcomes and disparities amongst these groups, which will be further followed up by some of the additional panelists who can give details depending on their topic of interest. Next slide, please. So as a broad overview, I wanted to show the testing cascade to show the different levels and from each question that we asked on the survey. So first, we asked individuals if they needed testing. If they then needed testing, we asked, were they able to get testing, of which the vast majority were able to. And then from those who did get testing, did they test positive? If they tested positive, were they symptomatic? If they were symptomatic, were they hospitalized? And if they were hospitalized, did they require ventilation or intubation? And one click, please. And on the right, this shows the same information as the left. It's just a more in-depth breakdown of each level and the average percentage for each level to give you a baseline as we move forward to talk about the disparities by race, socioeconomic status, education level, things like that. And so as you can see in our overall cohort, less than half actually needed testing. And then out of those who did get testing, or who needed testing, about 90% were able to get testing, which is great. And then out of those, 35% tested positive. And then out of those who tested positive, 42% were hospitalized. And out of those who were hospitalized, we had a very small cohort who ended up needing intubation, which kind of skews our data into showing that it's 82%. Next slide, please. So now as we look at each level, we can examine, in this case, as Dr. Gibson mentioned, some of us did some adjusted models. And so here I'm presenting an adjusted model that accounts for each of these sociodemographic variables and measures out and kind of gives a prediction of which factors are most highly associated with whether they were able to receive, with the outcome, whether that's, were you able to receive testing? Did you test positive? Were you hospitalized, et cetera? So for the first one, as you can see in the red boxes, we asked the question, did you need a COVID-19 test at any point during the pandemic? And if you just orient yourselves to this graph, because it'll be a similar graph for the next 4 slides, the red line at 1 indicates, the neutral odds ratio of 1, so the reference groups. And then you'll see to the left and to the right are each group and their relative odds ratios compared to that reference group. The reference groups all without any error bars are indicated at the beginning of each group. So for example, for race, we have non-Hispanic white as a reference group. And then as you can see below, each other race, non-Hispanic, Black, Latinx, and other have error bars associated with each of those. And so as we go along, we see that, interestingly, Latinx and higher educated, those with higher income in our survey, all suggest that they had higher testing demand and needed a test at higher percentages or had higher odds of needing a test compared to those who, the comparison groups. And then also along those lines, those who were older, as you can see, kind of a cascade and step down from the left, step up from left to right for those by age. And so those older than 34 all required fewer testing, which might have reflected a younger cohort of our sample size. Next slide, please. The next question that we then asked were you able to get tested? And so this was something that was actually encouraging within our cohort within the June respondents, in that, as you can see, there were no statistically significant differences by group. And this is after accounting for race, age, gender, education level, income level, and chronic health condition status, as all of these analyses have done. And so it suggests that even though there are individual differences in being able to get access to testing, that by and large, as different groups and cohorts and demographics, we were able to kind of equalize access to testing, which is really important given that at earlier points during the pandemic, this was not the case. Next slide, please. Sorry, I think it. Yeah, thank you. So looking at the test positivity, oh, sorry, one slide back, please. So then once we determined that people were able to get testing, we looked at, did you ever test positive for COVID-19 during the pandemic? And as you can see here, we have disparities by race, age, and disease status. And so those who were Latinx had higher odds of testing positive for COVID-19. And then again, interestingly in our cohort, those who were older than 45 and older had lower odds of actually testing positive for COVID-19, which reflects the shifting nature of the pandemic, and especially with the rollout of vaccines, how earlier on during the pandemic, we had a younger cohort or an older cohort who was reporting test positivity. But as the pandemic moved along and as vaccine rollout increased, we're seeing a younger population that's getting sick. And then lastly, as you can see with all of these slides, those, except for the last, those with chronic illness had higher percentages also testing positive, not even related to the outcomes from COVID-19. Next slide, please. And then the next question we asked was, were you ever hospitalized for COVID-19? And again, interestingly, in our cohort by age, we actually had a younger cohort, older individuals had lower odds of hospitalization rates. Interestingly, as we've seen, and this is kind of something that maps out across the world, but those who identify as men had higher rates of hospitalization. And we do know that globally, there have been higher infection and complication rates for men compared to women. And then lastly, again, those who have chronic disease also at higher risk or higher odds of having a hospitalization. Next slide, please. And then very last, we asked, were you intubated or required ventilation for COVID-19? And we recognize that in asking this question that we would have a skewed sample, in that especially for older individuals, anyone who was intubated or ventilated had a low chance of survival. And so we do have a survivor bias in this particular question, but we still asked it to get an idea of those who were ventilated, who survived. And so as you can see, still for those by race, this actually was those who identify as other, which includes mostly Asian American, Pacific Islander, as well as Native American and Alaska Native. And those who identify as men also had higher odds, or those identified men as higher odds of ventilation rates, whereas those who identified as another race had lower odds of ventilation. Next slide, please. So in terms of the summary slide, again, there are no major disparities in testing availability, which is improvement from prior iterations of this survey. We did also note that Latinx respondents reported higher test positivity. And so we think that targeted interventions that include multilingual approaches could be very helpful in reducing that gap and addressing some of the more systemic issues that could cause those disparities that we saw in both testing availability and testing outcomes. And then lastly, those with chronic health conditions had worse outcomes across the board, even when accounting for other sociodemographic factors, which really highlights the exacerbation of current health inequity that we're seeing by COVID. And so this is really a call to action for addressing some of these larger systemic issues in order to even out these outcomes. And with that, I'll pass along to Dr. Agarwal.
Actually, we'll pass to Dr. Dan Urchik.
Thanks a lot, Jeffrey. So great to be here, everyone. We will be presenting now on COVID-19 in pregnancy. Next slide. So I'll be presenting our results first on questions related to COVID-19 vaccination among pregnant women. A little bit about our methods first. In this module, we asked female respondents, have you been pregnant at any point in time since March 2020? So about 461 pregnant women of about 4,500 women responded indicating that they were pregnant in this period of time. We then asked them a module of questions on prenatal and delivery care, pregnancy outcomes, and breastfeeding. And we also looked as part of this analysis at pregnant women, how these pregnant women responded to questions in other modules within the questionnaire, such as COVID-19 infection and vaccination. So to understand the differences between pregnant women and non-pregnant women in the US population, we used a method called propensity score matching. And for some of the other analyses to obtain estimates that are reflective of the national population of pregnant women in the US, we weighted our participants by age and race for ages 18 to 54 using the National Survey of Family Growth. Next slide. So here are some of the demographic characteristics of our study population. Here we have the non-pregnant matched controls and the pregnant women. So pregnant women tended to be younger overall than the survey population, as we would expect. Roughly 30% of pregnant women were 18 to 24, and almost half were 25 to 35, with another quarter being over 35. They also had slightly lower education relative to the whole survey group, and the distributions of race and political party were slightly off from what we would expect in the US population of pregnant women, which we then adjusted for in the analysis. Next slide. So now I'll present some of the findings about vaccine acceptance. Next slide. So to get started, just a little bit of context. So we know that pregnant individuals, especially those with comorbidities, are at higher risk of severe COVID-19 illness and adverse pregnancy outcomes. And when vaccinations began in the US in December 14th, 2020, under the FDA emergency use authorization, many people asked about whether pregnant women could be vaccinated. And because pregnant individuals were excluded from the pre-authorization trials, many in the public were concerned about whether pregnant individuals should receive the vaccine. However, citing some early data, the CDC soon issued guidance that the vaccine should be made available to pregnant individuals, and they recommended, the CDC recommended that pregnant individuals have conversations about vaccination with their healthcare providers. So it was right around this time when all this was happening that the second pandemic pulse survey was conducted. As time went on, we've seen more and more data that show vaccine immunogenicity and safety in pregnant individuals, including several studies that have happened in March, that were reported on in March, April, and June. And since then, more and more pregnant individuals have received the vaccine. So in this new context, we then conducted this third pandemic pulse survey in May and June of this year. Next slide, please. So finally, some of our results. So here I'll present some comparisons from December 2020 and June 2021, as well as some data from June alone. So generally in these slides, I'll be presenting data for pregnant women and similar non-pregnant women to understand how pregnancy is related to acceptance of vaccination. So on the left, for December 2020, we asked pregnant women and similar non-pregnant women how willing they were to receive a vaccine. Significantly more pregnant women said they were willing to receive a vaccine, about 66% to 60%. So similarly, in June 2021, we asked a different set of pregnant women and similar non-pregnant women if they had actually received the vaccine. But now the results between the two groups were not significant. There was not a big difference, roughly 54% to 51%. However, more pregnant women at this point in time did report that they plan to receive a vaccine sometime in the near future, about 21% for pregnant women to 14% for non-pregnant women. So if these women intending to get vaccinated actually do, the rates of vaccination would be much higher among pregnant women. Also, just to note at the bottom left, bottom right, this don't want vaccination category, not ever wanting a vaccine as a response was much higher among non-pregnant women, 28% to 18% in June. In general, though, vaccination for both of these groups of women, the pregnant women and the matched non-pregnant women, were lower than the full overall survey of adults, including men and all ages. Roughly about 50 or 54% here in this group versus 64% overall. Next slide. So these are just adjusted results that confirm the earlier findings that I presented, accounting for the various demographic characteristics that could also be influencing the relationship. So on the left, for December 2020, we see pregnant women were significantly more willing to receive a vaccine. But in June 2021, there's really no difference between pregnant and non-pregnant women in terms of actually receiving the vaccine. But among this demographic of women in June 2021, those with more education, higher income, and Democrat political affiliation were more likely to have received a vaccine. Next slide. So we also asked in June, the June 2021 survey about flu vaccination status. So we did a little bit of a similar analysis to the slides I just showed. Here we asked women if they had received the flu vaccine in the last flu season. So many more pregnant women than non-pregnant women responded yes, about 66% to 50%. You can also see that there are higher rates of yes response for those with more education, higher income, and also among Hispanic women relative to Caucasian women. So accounting for all of these demographic characteristics, pregnant women had twice the odds of being vaccinated against the flu than non-pregnant women. Next slide, please. So we asked a couple of other questions. This one shows a question that read, since COVID-19 vaccines were authorized for emergency use in the US, did you ever seriously consider not getting a vaccine? So about 3/4 of pregnant women reported seriously considering not getting a COVID-19 vaccine at some time after they were approved for emergency use. So that's quite high, and it compares to only 42% of non-pregnant women. So that's, after adjusting on the right for all these other characteristics, that's 4 times the odds of considering not getting a vaccine for pregnant women versus non-pregnant women. Next slide, please. So in December 2020, we also asked women who said they were unwilling to receive the vaccine to share their concerns with us. Similarly, in June 2021, we asked women who had not received the vaccine what their concerns were. So on the left, we have December 2020, and on the right, June 2021. So for each of these questions, respondents could select multiple responses. So if they were concerned about safety or effectiveness, they could choose those, or just conspiracy theories, or just cost, or all of them. So overall, safety, effectiveness, and long-term health effects were the top 3 concerns. These were followed by believing the vaccine is unnecessary and believing in conspiracy theories. On the left, for December 2020, the individual responses for reasons for unwillingness were pretty similar between pregnant and non-pregnant women. There wasn't a major difference between these 2 groups. However, in June 2021, the non-pregnant women were much more concerned, especially about safety, effectiveness, and believing the vaccine is unnecessary. So although it's somewhat of an unfair comparison, these are different questions. We can kind of get a general sense from looking at them. And what we see is that between December and June, the magnitude of the difference in reported concerns is quite large between these 2 surveys. So in December 2020, many more unwilling women reported various concerns compared to unvaccinated women in June 2021. And you can see that depicted visually on the left. The bars in December 2020 are much longer versus on the right in 2021. So it kind of suggests that perhaps some of the concerns that were present in December 2020 are no longer as concerning in June 2021. Next slide, please. So we also asked women about who they trusted most for information on vaccination. And here respondents could only choose one response. So it was really looking at what is your most trusted source of information on COVID-19 vaccination. So in December 2020, what we see among pregnant women, the leading sources of trust were really split across primary care doctor, CDC, family, news, and social media, somewhere for each of them around 20%. But around non-pregnant women at this time, the CDC is by far the highest at 40%, followed by primary care doctor at 25%, and then for family, news, social media, and government, only about 10% each. So in June 2021, among the pregnant women, the leading sources of trust were primary care doctor, family, news, and social media, with family the highest at about 37%. But among pregnant women, we see physician, family, and CDC at the highest. So, you know, somewhat of a similar picture, but varying a little bit between the two groups and also over time. Next slide, please. So lastly, just to summarize some of our overall conclusions from this analysis, in December 2020, pregnant women reported higher willingness to receive the vaccine. However, by June 2021, this earlier willingness has not really yet translated into higher vaccination rates. Pregnant women in June were also more likely to report being currently scheduled for a vaccination. They're more likely to have considered never receiving a COVID-19 vaccine at some point since it was authorized. And they were less likely to be vaccinated compared to all eligible adults. We also saw some disparities in the vaccination rates among women of reproductive age for lower education, lower income, and Republican affiliation. And, you know, in looking at the key concerns for COVID-19 vaccination, we found safety and effectiveness, as well as to a little bit of a slightly lesser extent, conspiracy theories. And the most trusted sources of information for COVID-19 vaccination were primary care doctor, family, and interestingly, news and social media, which I think kind of speaks to, you know, potential areas for intervention. So thank you very much. I will now hand it over to Smisha and Lena to talk a little bit further on pregnancy and COVID-19.
Great, thank you, Dan. Next slide, please. So in the next round of these rapid fire presentations, we'll talk about, we've been exploring and we haven't completely finalized this analysis, but we've been exploring three plus areas of inquiry around pregnancy. One is, how does pregnancy alter a woman's risk for COVID-19, where we are interested in susceptibility and severity. And really, the jury is still out on some of this. We don't fully understand how a COVID positive status changes women's or if pregnant women are more likely to test positive for COVID. So that's one. And then whether their recovery or severity is different from a matched non-pregnant population. The second area is whether and how to quantify how COVID-19 has affected access to pregnancy-related care. And we measure this in terms of disruptions in routine prenatal care, changes in birth plan, and changes in postpartum care and access to support services. In our earliest survey about a year ago, our data suggested that about a third of the women had changed their birth plan from having a vaginal birth to having a planned C-section. They had also changed their birth plan from, a third of the women had changed their birth plan from birthing in the hospital to birthing at home. So we had seen a massive change in sort of what the routine, the normal is for giving birth in America. But we're seeing, we'll show you the most recent data on that. And then finally, and this is truly more exploratory in nature, since a lot of the data on this comes from hospital-based data sets, and we have a population-based data set, is we're exploring associations between testing positive for SARS-CoV-2 with pregnancy outcomes, with complications during pregnancy, birth, and newborn complications. So with that, I'll hand over to Lena to introduce the first two of these findings.
Yeah, thank you so much, Dr. Agarwal. Next. Yeah, thank you. So just to provide some context to this section, as Dr. Agarwal has mentioned, it's really unclear whether pregnancy increases susceptibility to COVID-19 at the moment. And there uncertainties remain around the prognostic role of inflammatory biomarkers among pregnant women with COVID-19. And the recent data are largely from hospital screening without an appropriate comparison group of non-pregnant women. And in our population-based data, we generated a matched comparison group of non-pregnant women, as Dan mentioned earlier. So also it's important to note that most recent studies have suggested that pregnant women are at increased risk of severe complications from COVID-19. These could include being hospitalized, requiring intensive care or ICU admission, and being placed on a ventilator for oxygen support. Next slide, please. So we're really looking at the cascade analysis among pregnant women versus non-pregnant women. We see that in the latest round of surveys that pregnant women are more likely to test positive for COVID-19 at 55.3% compared to 31% of the matched non-pregnant women. This follows a similar pattern as the data from the December 2020 findings. And while this suggests that pregnant women may be at higher risk of infection, as mentioned, existing literature reports that whether pregnancy increases the risk of COVID-19 infection remains unclear. So we want to note that we do not have data disaggregated by neighborhood, which could better explain the susceptibility to COVID-19, where women in high density neighborhoods are more likely to test positive. And here we also observe on the graph on the right, a higher rate of hospitalization among pregnant women or COVID-19 severity compared to non-pregnant counterparts. This difference of 54.3% is quite large and was reported in this round and is not significantly different from the difference in the hospitalization rate reported in December 2020 at 27%. Further research could look into reasons why this difference is larger, such as clinical management or vaccine receipt. So in line with published literature, our results show that pregnant women experience more severe COVID-19 complications than non-pregnant women. For example, the CDC has reported higher COVID-19 severity, including the higher likelihood of hospitalization, as well as developing respiratory complications that require intensive care or the need to be placed on a ventilator among pregnant versus the non-pregnant population in clinical settings. These more severe outcomes may be related to physiological changes in pregnancy, such as increased heart rate or decreased lung capacity. Finally, it is important to note that while it is difficult identifying comparison population for our pregnant women who most likely tested for COVID-19 in a hospital setting, our propensity matched non-pregnant population serves as an adequate comparison group in this case. Next slide, please. So after conducting a multivariable regression model among these pregnant women, we found that chronic conditions to be positively associated with a positive COVID-19 status at an odds ratio of 5.2, adjusted by income, race, political party, and education. The types of chronic conditions are listed here in the gray box below. And recent evidence shows that chronic conditions and pre-existing comorbidities may increase the risk of being infected with COVID-19 and further COVID-19 related complications. And while we see that the different races, such as African American, Hispanic, and the other race group, which consists of non-Hispanic Asian and Pacific Islanders, Native Americans, and Alaskans, all show a higher risk of positive COVID-19 status, none of these associations were significant in this model. Next slide, please. So similarly, we conducted a multivariable regression model for the hospitalization rate among pregnant women and found insurance status to be positively associated with hospitalization at an odds ratio of 3.6 after adjusting for chronic conditions, race, and political party. We also looked at education and income, but found no associations with positive or hospitalization. This finding suggests that women who are hospitalized are more likely to have insurance, which aligns with existing literature on the positive association between insurance status and COVID-19 complications due to higher exposure to the virus. It would be important to further investigate families and women who are not insured and see which sociodemographic and health behaviors make them different from the women who do have insurance. Next slide, please. So moving on to talking about the trends in prenatal care, we see that over 32.5% of women in this round of the survey reported more than 8 in-person ANC visits or antenatal care visits, and an average of 8.7 in-person ANC visits throughout the overall pregnancy. This is higher than the average of 5 virtual ANC visits reported by pregnant women in this survey round. And these findings are significant because, as Smisha mentioned, in the previous round in December 2020, 85% of women transitioned from in-person to virtual prenatal visits. Furthermore, only 54% of women reported in-person prenatal services to be available to them in the last round. So during the initial stages of the pandemic, where much more of the prenatal care had shifted online and more women switched to virtual care due to their fear of exposure to COVID-19, women only made in-person visits if they, for example, experience abnormal fetal movement. Overall, we observe a positive trend of in-person ANC visits returning back to normal or pre-pandemic levels, and the percentage of virtual visits or percentage-wise going down. Next slide, please. And when we look at birth delivery by C-section, we see that a little bit over 25% of women had a C-section in this survey round, which is slowly reaching back to the average rate of C-sections throughout the country in the US at about 31%. In the first round of the National Pandemic Pulse Survey in September 2020, 35% of pregnant women reported changing from a vaginal birth to a C-section, with or without medical indication. Similarly, 19% of women in December 2020, the second round, reported changing their birth plan from vaginal birth to C-section. This suggests that in the lieu of the pandemic, pregnant women preferred to give birth in a more controlled situation where exposure was lower to COVID-19. However, in the most recent survey round of June this year, we see that the primary reason for C-section was a prior C-section, as seen on the graph on the right, which suggests that indication of C-section was indicated rather than preference. So overall, we see C-section rates returning back to normal, which is a good thing. Next slide, please. So finally, we're going to look at the postpartum services trends among pregnant women in this round, and we see overall high rates across most postpartum services, including skin-to-skin contact between mother and baby, breastfeeding following birth, COVID-19 precautions, and mother rooming with the infant at birth. So COVID-19 precautions include, as you see on the left, wearing a mask, practicing proper hygiene, or placing the baby in an isolette, which is a plastic enclosed bassinet at birth. Unpublished data regarding mother-to-infant transmission in the postnatal period has been reassuring when appropriate precautions are taken. For example, in a recent study of 116 COVID-positive mothers who breastfed their 120 newborns, all newborns tested negative for COVID-19 and were asymptomatic. In this study, the infants roomed with their mothers in a closed isolette, and mothers used a surgical mask and careful hand hygiene before breastfeeding and other interactions with the infant. In our survey, we see that over 73% of mothers breastfed their babies at birth, and of the 88% of mothers who roomed with their infant at birth, around 85% reported any COVID precautions taken in the room, which is also positive. And this is reassuring to see that COVID-19 safety measures are being taken, especially at birth, when the neonate and the mother are vulnerable. And a lower percentage of newborns, as seen as the top row of the graph, were tested for COVID-19 only at 39%, which could be due to the lack of evidence of intrauterine vertical transmission of COVID-19 from mother to baby, but an interesting finding or area to further investigate. Thank you, and I'll pass it on to Dr. Agarwal regarding pregnancy outcomes.
Great. Next slide, please. Great. So a little bit of background on what we understand about the impact of COVID-19 on pregnancy outcomes. We know that that a report of a positive COVID status is associated with certain adverse pregnancy outcomes. A lot of this data comes from surveillance data or from hospital records. And so we know right now that COVID-19 status, positive status, is associated with a higher likelihood of preterm birth, of stillbirth, late intrauterine fetal demise, and low birth weight. But there is lack of sufficient evidence in all of these areas. We just have some preliminary studies, as well as on pregnancy loss, in earlier pregnancy loss, such as miscarriages. Positive COVID-19 status is also associated with pregnancy complications. The ones that have been more recently documented are around preeclampsia and gestational diabetes. And a positive COVID-19 status, we don't understand a lot about how it affects newborn outcomes, and the findings are not consistent. We don't understand, like Lena mentioned, about intrauterine transmission of COVID-19. It has not been widely reported. There's been no reported incidence of increase in congenital anomalies. And the pathway to understanding this is still unclear, and some of it might be potentially due to reduced access to care, maternal stress, as well as other immunological pathways. So I should pause here and state that a lot of the data that I'm presenting, we have fairly small sample sizes, and so they're really intended to be signals and associations, and they don't really suggest something conclusively. And that really the conclusion of presenting this is that we need more studies that are hospital-based with larger sample sizes, as well as population-based studies to look at this. Next slide, please. So we had a sample of 208 women with pregnancy outcomes. As Dan mentioned earlier, we had a larger sample of women who reported ever being pregnant in the last year, but of those, only 208 had a positive had a pregnancy outcome. Of these 208 women, 65% had reported a live birth, and the remaining reported either a miscarriage, a stillborn birth, or death of an infant, or demise for other reasons. Amongst those who had a live birth, we analyzed that data set further, and we look at amongst those who reported fetal complications and delivery complications, as well as pregnancy complications. Among the women who had live birth, the way that I'm presenting the next set of analyses is we're comparing women who reported a positive pregnancy test anytime during their pregnancy, a positive COVID test anytime during their pregnancy, versus those who did not have a positive pregnancy test. Next slide, please. So we see that in this slide that women with a positive COVID test were more likely to experience adverse pregnancy outcomes. So here we look at those with live outcomes, and the green is those who had a negative pregnancy test, and they were more likely to have a live birth. And so if we sum the rest, we see that those who had a positive pregnancy test were more likely to not have a live birth, essentially. Next slide, please. We disaggregate this by race and see a similar pattern across all population groups. But in the Black population group, we see that this trend is significant, where those who had a positive COVID test were less likely to have a live birth. Next slide, please. We look next at pregnancy complications, and I'll go into how that was defined. We looked at newborn challenges, fetal complications, delivery complications, and pregnancy complications, and found that all of these, there were significant associations between testing positive for COVID and having some complications along birth or in the postpartum period. Next slide, please. For pregnancy complications, we see a significant difference between women who had a positive COVID test and who had pregnancy complications. Next slide, please. But when we adjust it for chronic conditions as well as for demographics, we see that that association is no longer significant, and actually chronic conditions is partially the driver of some of the complications that we experience during pregnancy. I also note that ideally we would control these models for the gestational age during which COVID-19, during which the women tested positive for SARS-CoV-2, and we have not yet done that, but that is the next step for our analysis. We also see that in the previous slide that socioeconomic status was not associated with complications, and race was also not significantly associated with complications. Next slide, please. Women with a positive COVID test were more likely to have delivery complications. And this, when we control for chronic disease and other demographic factors, remains positive. Next slide, please. And so we see that chronic conditions are a factor that have contributed to delivery complications, but a positive COVID test, again, is one of the factors. And as a next step, we would need to disaggregate this by when the women tested positive for COVID during their pregnancy. Again, race and education are not significantly associated with pregnancy complications. Next slide, please. So like I mentioned earlier, that these findings are intended to be a signal that these are areas that we need to look into further and look into more hospital-based studies where we are able to account for severity, where we do have some biomedical markers that we're able to account for, as well as baseline, more details on pre-existing conditions. So this is largely exploratory. However, In summary, we see that pregnancy status is associated with testing positive for COVID-19 and for hospitalization. This is a matched cohort, population level cohort of pregnant and matched non-pregnant women. We also see that those who are testing positive for COVID-19 among pregnant women are more likely to experience adverse pregnancy outcomes as well as complications. And there are significant racial differences in these associations. And those who test positive for COVID-19 are also more likely to have delivery complications and complications for the neonate. I will actually stop there. I have talked about some of the limitations of the data and the next steps. And so we should keep those in mind because I think they're quite important. So I'll pass on next to Shivani to talk us through substance use and mental health.
Great, thank you. So hi everyone, I'm Shivani, and I'll be discussing the findings from both the mental health and substance use modules today. Just to note, for the mental health module specifically, I'll be presenting analysis conducted by our colleague Madhu Jalan, who is not present for the webinar today. Next slide, please. So as we all know, COVID-19 is a major source of stress globally. It has caused significant challenges and disruption. Next slide, please. So our questionnaire for the National Pandemic Pulse Survey utilized the scientifically validated Patient Health Questionnaire, or PHQ-4, which measures anxiety and depression through a set of 4 questions. The questions are measured through a four-point Likert scale, as you can see here, of not at all days, several days, more than half the days, as well as nearly every day. There are 2 questions that assess symptoms of anxiety, which are number 1 and 2 in that first box there. And then there are 2 questions that assess symptoms for depression, which is numbers 3 and 4. And then a score for either that is either equal to or greater than 3 suggests it to be clinically significant. The PHQ-4 survey can also measure psychological distress by summing the responses across all 4 of these questions. So a sum of 0 to 2 would be considered normal, 3 to 5 would be mild, 6 to 8 moderate, and 9 to 12 severe. And I just wanted to share these thresholds as they're useful to keep in mind as the rest of the analysis does use them. Next slide, please. All right, so just to go a bit backwards, for the last round of the survey, which was conducted in December, we wanted to compare both pre-pandemic as well as during pandemic psychological distress. And so we looked at the Health Information National Trend Survey, which is known as HINTS. It's an annual national representative survey conducted by the National Cancer Institute, who also uses the PHQ-4. And so when they conducted their survey back in 2019, they reported that around 25% of the population had psychological or reporting psychological distress. When we did the survey in December of 2020, we saw an 87% increase, which is quite a large magnitude. So 48% of the population was reporting some level of psychological distress. Next slide, please. So here you can see that during the June 2021 survey, the most recent administration of the NPP survey, we actually see a decrease from December 2020 to June of about 12%, which is nice to see, but it's still larger than what was reported pre-pandemic times. One possible reason for this could be due to increases in vaccine access and coverage. Next slide, please. So this slide is just showing you the different levels of distress experienced. So it was 42% overall, but as you can see here, when you break it down by the levels, around 11% reported severe, 15% moderate, and then 17% mild. Next slide, please. This slide is just showing you the presence of anxiety or the reporting of anxiety symptoms and depression symptoms. So around 26% of respondents reported clinically significant levels for anxiety, and then it was 25% for depression. Next slide, please. Now, this slide is looking at it by race. So once we stratified the reporting of distress by race, we can see that higher levels of distress were reported amongst the Latinx respondents, which is that top bar there. And they were reporting above theirs was over the average of the overall population, which is this black bar, which represents 42%. And so it's substantially higher than the other racial and ethnic groups. Next slide, please. Now this is looking at it by age, and so you can see with the outlined red box that younger populations are reporting greater levels of distress compared to those over the age of 45, and over half of each of these subgroups are reporting distress amongst their subpopulation. Next slide, please. So we also looked at the experience of job loss during COVID-19, as well as lack of health insurance in relation to the reporting of psychological distress. As you can see here for the top graph looking at lost job, almost 70% were reporting some level of distress, and around 21% of it being severe, compared to those who did not lose their job during COVID-19. You also see something similar within health insurance, where those who do not have health insurance are reporting greater levels of distress than those who have it, with it being around 60% for those who do not have it. Could you go to the next slide, please? So this slide is looking at the reporting of vaccination status compared or association with psychological distress. And so for this question, we just asked what their vaccination status was, and their response options were either yes, they were vaccinated, no, but they were scheduled to be vaccinated, the third is no, they're having difficulty accessing vaccines, and then the fourth is no, they do not want to be vaccinated. And so as you can see here within the middle two bar graphs, those who are not vaccinated but scheduled and those who are not vaccinated but having difficulty accessing are reporting greater levels of distress compared to the vaccinated and intentionally unvaccinated populations, which we thought was significant. Next slide, please. So we also looked at associations between the accuracy of COVID-19 news from different types of media sources. This included like social media, as well as more traditional sources like broadcast TV, cable TV, and print news. Our findings were largely similar to what we saw in round 2, which was the version implemented in December, which indicated that those who trusted social media as a reliable and accurate source of COVID-19 information were also reporting higher levels of distress, especially when compared to more traditional news sources. As you can see, this was sustained during the survey, where it was around 63% of the those who trusted social media reported distress. This also likely suggests and buttresses concern around the impact of misinformation and conspiracy theories that are abundant and rampant on social media, and how they might be adversely impacting people's mental health. Next slide, please. So finally, as demonstrated through the slides, the experience of mental distress amongst the population during the pandemic is definitely quite striking. It was enlightening to see how the overall distress levels reported has improved since the last round of the survey, though it is still larger than what was seen obviously before the pandemic. So in terms of our results, we did also find that mental distress was strongly associated with trust on social media for news, age, race, job loss, the delay in receiving medical care, as well as the lack of health insurance. And so that's going to conclude my specific discussion around mental health. And so next slide, please. So now just to kind of move on to the next module, I'll be now talking about the substance use module of the survey. To provide some context around this, as you might have seen in the news in the US at least, that during the pandemic, we have seen increased sales and consumption for marijuana, tobacco, and alcohol. And I'm specifically pointing out those three because that's what we looked at in our survey. This has also been seen in like observational and epidemiological studies. Oh, next slide, please. I'm highlighting one done here by one of our colleagues, Dr. Thrill, on increased alcohol consumption during COVID-19 in the US. Next slide, please. So in the US, around 13% of adults had started or increased substance use, and that was from June 2020 done by the CDC. This is significant because problematic substance use especially is, there's a lot of concerns around its effect on the immune systems, increased susceptibility to COVID-19, as well as like the downstream long-term side effects that we're still looking into. Next slide, please. So now bringing it back to our questionnaire specifically, the substance use module was actually, it was a relatively short module, so that we asked each respondent a two-part question essentially. So the first question was if they had ever used either alcohol, tobacco, or marijuana, and these were as separate questions. And then if they responded in the affirmative, then we would follow up for each if there had been any change or has there been any change in their use for smoking, alcohol, or marijuana consumption? And for that second follow-up question, their response options would either be they're reporting no change in behavior, they're reporting yes, there is a change, but it's less than usual, or finally, yes, there is a change, but it's more than usual. And just kind of as an important note to emphasize, we did not ask respondents what their pre-pandemic substance use behavior was like. Therefore, we can't speak to what increased, decreased, or no change in behavior like actually or tangibly means, because we don't have that baseline. It's just based on their perception or perceived self-report. And then in terms of the analysis that I'm presenting today, I'll be sharing, I ran logistic regressions adjusted for race, age, gender, income, experience of job loss, psychological distress, and then vaccination status. And then I ran it separately for both increased use for each substance, as well as separately for decreased use for each substance. Next slide, please. So this slide is just showing us how many of our respondents have ever used a specific substance. As you can see here, amongst our respondents, around 70% reported ever using alcohol, 40% tobacco, and then 33% marijuana. For alcohol, we noted that's actually lower than what was reported in the 2019 National Survey on Drug Use and Health, who had reported around, I think, 86% of the population having ever consumed alcohol. So our sample might not be entirely representative there. Next slide, please. So this slide shows that follow-up question that I mentioned earlier about change in use behavior. And so you can see here that for the most part across all three substances that there was largely no change reported, but you can also see that for those who had ever used tobacco, around 17% were using more than usual due to the pandemic versus 23% decreasing their use. For alcohol, it was also largely comparable, where around 17% were simultaneously increasing their use in or increasing their alcohol usage versus decreasing. And then for marijuana, 23% had been increasing their marijuana consumption and 20% were decreasing. Something that could be driving the comparable rates of both increase and decreased consumption could be that for increased stresses related to the pandemic and beyond could drive people to start drinking or consuming substances more. Whereas for a decrease in use could be driven by the fact that concerns around impact on health, especially exacerbated by COVID-19, could drive people to potentially change their behavior around consumption. Next slide, please. So now I'll be presenting the logistic regression models that I ran. And so just to provide some orientation to the slides for the following few, because they will all look similar, is that alcohol will always be on the top, tobacco in the middle, marijuana on the bottom. The leftmost column with the orange colored graphs will be representing increase in use. And then the rightmost column with the graphs in blue are decrease in use. And then I'll have the reference populations listed here. So for this specific slide is looking at the relationship between substance use and race. And as you can see here, there wasn't much of a strong association, as you can see, for increase in use across all three substances for race. But when you look at decrease in use, you can see that Latinx and non-Hispanic Black respondents had greater odds of reporting reduced alcohol consumption as well as reduced marijuana consumption. And then Latinx respondents had increased odds, or were more likely to report decreased consumption of tobacco. Next slide, please. So this slide looks at the relationship between substance use and age, and then the reference population is 25 to 35. And so across the board, like if you do a quick overview, you can see that older age populations, so 55 plus, were reporting, or more likely to, were less likely to report increased usage in alcohol, tobacco, and marijuana. And for a decrease in use, they were also less likely to report decrease in use across all three. For marijuana, you do see that the 18 to 24 subgroup were reporting increase in use for marijuana, more likely to report increase in use for marijuana compared to the ages 25 to 34, as well as less likely to report a decrease in use for marijuana for decreased consumption. And this could be driven by the fact of there's more states are legalizing marijuana, as well as this includes the 21 age group where you can become eligible or legalized to consume. Next slide, please. All right, so now this slide is looking at education with the reference population being less than a high school degree. And so as you can see from the slide, there's not much strong association here, with the exception for increased alcohol consumption and increased tobacco consumption. And so for alcohol, you see that those who had greater than a high school degree essentially were more likely to report increased alcohol consumption compared to those with less than a high school degree. For tobacco, it was those who had a bachelor's degree or greater were more likely to report increased tobacco consumption compared to those without a high school degree. Next slide, please. Now looking at the relationship between substance use and income, you can see there's not a lot of strong associations here, with the exception for decreased alcohol consumption, where you can see that those making between $40,000 to $99,000 a year were less likely to report decreased alcohol consumption compared to those making under $20,000 a year. Next slide, please. Now looking at vaccination status, which again, I think as mentioned earlier, it's the response options where that they don't want a vaccine, are having difficulty accessing a vaccine, or they are scheduled for a vaccine, and the reference population is vaccinated. They are vaccinated. You can see that that those who are intentionally unvaccinated are less likely to report increased alcohol consumption, are less likely to report decreased alcohol consumption, decreased tobacco consumption, as well as decreased marijuana consumption. Something interesting that we saw here was that those who are scheduled for a vaccine were more likely to report increased tobacco consumption compared to those who were vaccinated. Next slide, please. Lastly, I'm going to share some of the significant stressors that we identified. So this slide demonstrates some of the strongly statistically significant findings from the regression models, and it was done amongst those who experienced job loss compared to those who did not during COVID-19. And then it also looks at psychological distress, which was calculated using the PHQ-4 scale compared to those who are normal. And so as you can see here, that across the board, those who have lost their job during COVID-19 are more likely to report increased alcohol, tobacco, and marijuana consumption compared to those who did not. And then same for psychological distress, in that those who are reported to have psychological distress were more likely to report increased alcohol, tobacco, and marijuana consumption compared to those who aren't. Next slide, please. And just to kind of emphasize how strong that association here, this is showing the overall, like with all of the adjustments, all the covariates, all of the models for alcohol, tobacco, and marijuana for the increase in use. And you can see how strongly psychological distress is associated with each of them compared to the other covariates. Next slide, please. Similarly, this one is showing the same thing, but for decrease in substance use across all three. And you can see that for decrease in alcohol consumption, psychological distress was more strongly associated with it. But then for tobacco and marijuana, it was loss of job that was more strongly associated with a decrease in substance use. Next slide, please. All right, so that essentially concludes my analysis for the substance use and mental health modules, and it is the last module for today's webinar. Just to kind of give you a quick summation of what I shared today, there were strong associations seen with psychological distress and experience of job loss due to COVID-19 across all three substances, as well as for increased and decreased use. We did see that race wasn't as strongly associated with increase in use, but we did see it strongly associated with a decrease in substance use for Latinx respondents. And then for education, we did see a strong association between increased alcohol use for those with greater than a high school degree compared to those who had less than a high school degree. And then finally, I just wanted to kind of mention the importance of mental health and substance use services. So it's just important to note that access to mental health and substance use mental health and substance use services has been challenging even prior to the pandemic. It's often been unaffordable and inaccessible to many. So as we see the US reopening again, it will be important to recognize the significant trauma and challenges that we are and likely will continue to experience. So it will be important to emphasize and have policies in place to support increased human resource capacity with specific focus on at-risk communities, as well as continue to invest in and sustain investments in mental health and substance use services overall. That's it. Thank you.
Great, thank you, Shivani. So that was a lot of data and a lot of rapid fire presentations. We can take a pause here and see if there are any questions. Folks can raise hands, or if there are any reflections. I see that there is some back and forth in the Q&A box, but I'll give folks who are still here a minute to see if there are any questions or reflections on what we've talked about. Okay, maybe I will start with a very, very brief summary to just give you the highlights. Is that I think we see across the board that there is a lot of good news as well, right? Improvements in access to testing. We saw racial differences in some of the earlier surveys, which we no longer see in access to testing. We also see that there are no significant differences in vaccine acceptance between various populations, and also between the pregnant women and matched non-pregnant women. And disparities in vaccination rates amongst women of, we do continue to see disparities in vaccination rates amongst women of reproductive age with lower education, lower income, and with Republican affiliation. For prenatal care and birth planning, we're seeing a trend towards return to normality, where previously a lot of the care was largely virtual or decreased quality of care is now returning back to what normal in-person care or a mix of in-person care and virtual care, and birth planning with more general trends towards indicated C-section rates. COVID-19 positivity is associated with adverse pregnancy outcomes and with pregnancy and delivery complications. We're looking forward to doing more analysis in those areas. And then finally, we note higher levels of anxiety, depression, psychological distress, as well as association between psychological distress and substance use, which I think warrants action, since it's going to have long-term implications for the populations. If there are no questions or comments, I will let you know about the next part of this webinar next week, where we'll be talking about general vaccine acceptance hesitancy, masking intentions. We'll also talk about misinformation, food insecurity, and access to nutrition assistance, as well as how COVID-19 has affected parents and schooling and the well-being of children. So thank you everyone for your time. The recordings for this should be available. I think Megan will share a link, and for more information, please feel free to go to covidinequities.org. And thank you very much for making it this afternoon.